Good morning. I'm Judy Check, a retired RN who worked here at Frederick Holy Family Memorial for 47 years. I was asked to speak about how the profession of nursing has changed over the last 50 or so years, which I was a part of. Over that time period, I worked in several different departments with several different roles, and I'm going to sort of weave those experiences into my comments today. So I guess I'd like you to think about how things have changed for you as well, not just in the world of nursing. I know I see one nurse here. And if you've got anything to add that you think I didn't talk about, we can talk about at the end of the discussion. Okay? So nursing is really one of the most rapidly evolving professions in medicine. Over the past 50 years, the practice evolved almost beyond recognition. I think if I, even with my background and my certifications, were to come back to try to work on the floor here in the hospital or even in a clinic, I feel like I'd have to go back to school or have a very great comprehensive refresher class. That's how much things have changed. Just like everything that I did as a nurse back in 1976 when I started is done a different way or not done at all. So nursing has changed. I think we can all agree on that, along with healthcare as a whole. When you think about how nurses were educated, that has significantly changed. Holy Family Memorial, or Holy Family at the time, had their own school of nursing, which I think the last class was 1975. I could be wrong, and within a year. 76, okay. I knew I was close because I graduated in 76 and it was close to that period of time. So those nurses were educated in Manitowoc for the most part and trained here at Holy Family Memorial. So that diploma school closed, and really most of the other diploma schools in Wisconsin closed very close to that time. And education then moved to the technical schools where you could achieve an associate degree, or to the universities where you would get a Bachelor of Science degree in nursing. So that was a big switch. And the training was different. I know I'm a BSN grad, and my hands-on training was significantly less than the nurses who were trained here at Holy Family. So that's sort of a negative when you start. You do end up picking up on things quickly, but it was a difference and a change. It was also a change, I think, for my nurse manager when I started. You know, she was kind of like, how do I handle this person? There weren't that many degree nurses at the time. So an RN needs to obtain an associate degree or BSN and still pass your state exam to become an RN. In addition to the RN license, you can become certified in your specialty area, and this is something that was not available when I first started, but became available, I would say, probably in the 1980s. And certification, or advanced certification, is a mechanism for recognizing you for your skills and knowledge that you have in a particular specialty. It's a form of credentialing above and beyond your entry-level education. And here at Frederick Holy Family Memorial, I'm happy to say we have many certified nurses in their specialty areas. So that brings additional knowledge, education. They have to pass a very vigorous test to get that certification. So it's only a plus for the organization to have these certified nurses. Nursing was traditionally a woman's role or a woman's occupation, and actually that's still true. So that's something that hasn't changed that much, in that 90% of the nurses in our nation today are still female. So that I thought was kind of interesting. Today nurses are given a lot more autonomy than they had in the past, and that does vary with the Nurse Practice Act and from state to state, but in general it's true. And they also have more mobility, and that got me to thinking about the traveler or the traveling nurse or a lot of these companies that popped up who supply us with nursing staff when we don't have enough. So I know that when I was early in my career, we had very few travelers here. If we had 10, that would be a lot, and it was probably more in the single digits. I know that during COVID, actually a lot of nurses left the profession. If they were boomers like myself and close to retirement, it was kind of a good time to exit. Some of them were just scared and didn't want to have to deal with the uncertainty of that whole time and left. And anyway, it left healthcare short, and not just here in Manitowoc, but everywhere. And that's, I think, when the traveling nurse really boomed. And we had, I don't really know what we have today, but I know like a year ago we had at least 30 or more travelers at any given time in our organization. So that was a big change. I was thinking about what I used to wear when I first started as a nurse. So it's like, wow, why did they make us dress up like this? So we had white uniforms, white hose, white shoes, often this shoe called a clinic shoe. So if any of you come from my era, you will know what that is. And we wore hats, and then we wore our pin on our dress. So those were very traditional parts of the nursing uniform, especially the hat and the pin. Shortly after I started here, we lost the hat, which was very nice. I mean, I can remember bending over the bedside and my head flopping, or my hat flopping, and it's only adhered with a bobby pin, so it could easily fall in the bed. It was actually probably a source of an uncleanly thing to be wearing, because it was not something you could throw in the wash. So eventually we got rid of the hats. And then it wasn't until like the 1990s that nurses started wearing non-surgical scrubs. So the surgical staff or the operating room staff always wore scrubs because they had to. But the rest of the staff, and including throughout the hospital, didn't always have the non-surgical scrubs. But then they became commonplace, and the white uniforms we put aside. I think my hat ended up in my Halloween costume box in case somebody needed something. But and so now our nurses are much more comfortable. They're wearing tennis shoes. They're wearing a shoe that's comfortable for them. They're wearing clothes that are comfortable, you can move in, and are easily laundered, and just a change of the times. When I think back when I started here, we had 125 beds, I believe. It was a whole different time. A lot more staff. I started out in the ICU, CCU area, and it was an 8-bed, it was a 7-bed unit. And our little med room used to be like so full of people at report time that you had to walk out because you couldn't get enough air. But that soon changed as medicine changed and healthcare changed. Our lengths of stay changed. People weren't in the hospital as long. We had surgery centers or same-day centers where they were in and out. And what was the other thing that? Home health care became more available, so people could be cared for at home. Really, you had to be sick to be in the hospital. When I was thinking about how beds have changed, I got onto the thinking about traction. So we used to have to put patients in traction if they had a broken bone. And then they had to stay in traction, and this was not something you could do at home, so they were in the hospital for long periods of time. But with advances in surgery and being able to pin and plate bones and administer or have pain medications that could that worked well and allowed people to go home, those lengths of stay became much less, and traction gone. Now, I think they still use it for some spinal conditions, but in general, you don't see beds with traction anymore. They were always a problem, at least for me, because in ICU we didn't set them up. We didn't see them that often, and you know, it was a lot of working parts there. So a lot to know what to do with. So along with all of these advances, it made less patients in the hospital, right? So then you need less staff. So the numbers of staff decreased and their roles sort of changed. And in nursing, we tried different models of nursing. There was one called team nursing that was very popular for a time, where you had a small group of people that cared for another small group of patients, and you all had your roles. Then we moved on to primary nursing. Lori, do you remember any of these? So primary was one person, one patient, and you took care of that patient through their duration. They were all in an effort to provide quality care and, of course, be efficient. So it's sort of a cultural, societal thing. As the society goes, nursing kind of follows along with how they're providing care. Care management is one of the newer concepts, and this is a model that involves coordinating and managing your patient care across the healthcare system. Case managers are usually involved throughout an episode of illness or disability, and case managers are really used to keep the length of stay at a reasonable number of days, and that has a lot to do with Medicare. So as reimbursement changes, we have to change also. So I'm going to take a look at a hospital nurse in 2024 versus a hospital nurse up to 50 years ago. What kinds of things they see and are doing that are different. One thing is the shift work. So back in the day, we had 3 shifts. That's just how it was. A day shift, a PM shift, and an evening shift, and they were 8-hour shifts, period. Today, you can work a 4, a 6, a 8, a 10, a 12, a weekend shift, very flexible, except no work from home in this profession. But it's nice that it can meet your needs on a variety of levels there. Nurses walk around with phones in their pockets. They get alerted to patient needs and they can respond quickly. That's a big change. When I think about how we had our hands-on care with patients, everybody got a full bath every day. That included oral care, head to toe washing, with our little basin of water that you had to change out a couple times, and a full bed linen change. Honestly, the first time I found out they didn't change beds every day, I was shocked. It just seemed like something that would never go away. But now they change beds as need be, and they use a lot more of the disposable pads. And they also use disposable, like these warm, moist towelettes, and that's how they bathe the patient. So that's a big change, and really that's a big time saver. Vital signs, blood pressure, pulse, temperatures are all mostly taken electronically. I think everybody still knows how to do a manual one, but electronically is how that has moved. Our medications are prepackaged by the pharmacy. Everything is mixed by the pharmacy. We used to add our drugs to our IV bags. Not all the time, but not infrequently. And individually packaged for the patient. The meds are kept in the patient's room versus a med room. This has it is a way of actually being much safer as far as med administration goes. So a big positive there. Our pharmacists are available to speak with patients and families and educate them on their medications. Use of patient lifts. So My recent occupational health background, this is like, makes me, this makes this topic dear to my heart in the way of having safe patient handling equipment available. Um, when I started, we had a Hoyer lift that you had to crank like this. That was it. That was the only way you could move a patient unless you did it physically yourself. We also would use large plastic garbage bags, clean, to put under the draw sheet as a friction reducer, um, to help pull patients up in bed if they were heavier and we couldn't handle them. That actually it still exists today, but in a much more patient-friendly manner, in that they're made out of different materials, and they just call them slips, and very popular, and most patient beds have one available for them. So the other kinds of equipment, the lifts, the ceiling lifts, I mean, you can assist to ambulate with a device. You can move them from bed to commode with a device. It is a big patient pleaser in that you're not grabbing and yanking on them, and it's more safe for the patient and for the nursing staff. We have patients on telemetry, so their heart rhythms are getting monitored while they're on the floor. We occasionally have ventilators on the floor, on the medical floor. This is not something you saw years ago. So the acuity of the patients has increased dramatically. Like I said, you need to be sick to have an overnight stay in the hospital. IV pumps are automated. I think that it feels like those came relatively soon after I started. But I do remember counting drips and calculating it to get a drip rate so that they got the right amount of medication or IV solution over a period of time. So that also was a big safety improvement and time improvement. I do not remember using disposable gloves very much when I started at all. That sounds pretty strange, right? Because like I use them in the kitchen all the time now. Were they not available? I just don't think they were a thing. We had gloves, but they were sterile, and we used them primarily for sterile procedures. But if we were just, cleaning somebody up, we weren't using gloves. However, I think what changed it was when AIDS came on the scene. So AIDS came on the scene in the mid-'80s or so, and then blood. You didn't want to have blood-to-blood contact because then you could potentially get the disease. So nobody wanted to be touching blood anymore. I think I touched a lot of blood in my days. We must have washed our hands a lot. But after that, we were wearing gloves. So that's sort of an interesting change. Back to the beds, we have these smart beds now that weigh patients, assist with their movement. They have special mattresses on them to prevent skin breakdown and injury. They reduce the amount of time that the nurse spends adjusting equipment and supplies and provide a lot of safety. So a good smart bed, and I know that beds get changed out relatively frequently, and there are always more and more technology on the bed. So much so that sometimes they get hard to operate, but in general they're safer for the nurse and the patient. So in the late 80s, I was working in the education department at that time. Computers were coming on the scene, and Holy Family decided they were going to move to computer order entry. So that meant if we needed to submit a lab order or an order for an x-ray, we had to put it into the computer. What we did previous to this is we had little slips of paper that you check off what you want, put them in the tube system, and send them to the lab. So that became our backup system, and the computer was our primary system. I will tell you, we had nurses who threatened to quit over the fact that they were going to have to start using computers. Like, when you think of it today, it's like crazy because our phone is basically a computer. But they're like, I'm not doing it. You can't make me do this. Like, there's going to be no other way for you to enter an order. Like, you can't be a nurse without learning this. So obviously, they all ended up learning it. They all came along, kicking and screaming at times, but it got done. And today, of course, all of our notes, our data is entered into the computer. There is no paper involved. I can remember having just like sheets of paper, little note paper in my pockets. And if it was a really busy day in the ICU, you just never got to the desk to document anything. So you had to keep all your notes, and then you'd sit down after shift and then enter everything. So this is a big benefit. You are putting the data in as it happens. The computers were at the nurse's station at first, and now they're in the patient's rooms, or they're moving with you from room to room. This also allowed for the advancement of the electronic medical record, so the EMR, and that's been an awesome advance because our providers can then share patient information with other providers in a much easier way. I don't know if any of you remember the Cardex. That was our other method of communication. It was like a flip chart kind of thing. And we had like all the patients in a row that were in a section on the floor, and basically everything you did for them, you know, what their diet was, what medications, schedule they were on maybe, what kind of activity they could tolerate, special needs, you know, family members, you might have their name on there, or somebody needs to be called at a certain time. At any rate, it was really our only means of communicating shift to shift what was going on and providing some continuity of care for that patient. So that piece of paper's gone also. As a critical care nurse in 1976, we were asked to respond to code blues throughout the institution, throughout the organization, including the emergency room. And you have to remember, at this time, there were no 24/7 emergency room doctors. There were no hospitalists. On PMs and nights, there was potentially no doctor in the house, period. So we couldn't have our emergencies occur only on the day shift. So when they occurred, it was the critical care nurses' role to respond and to get things moving until the doctor got there. So that meant we had to start the IV. We had to make sure that respiratory therapy would respond, so they would take care of the airway. We had what we called a cookbook. It's kind of like a Bible of how to administer drugs depending on what situation you have in front of you. So you would interpret the heart rhythm, and if it was this rhythm, you gave that drug. If it was this rhythm, you gave that drug. And I have to say, there were times where I was in the emergency room in charge of a code, and the doctor couldn't get in, and he was conducting it over the phone. So that's just how it was. So a lot more security and safety when you've got a doctor in the room. Let's see. In conclusion, I guess I just want to say that there are things that haven't changed, and that is a good thing. So the nurses still use something called the nursing process, and it's a systematic guide to client-centered care that has 5 sequential steps. And I actually wasn't sure that it was still being used, but like this is something I learned in nursing school. It kind of has carried me through, and it's actually a good scientific way of assessing a lot of situations, not just patients. But it includes assessment, that's your first step. Then you diagnose. I'm saying not like a doctor diagnosis, but then you plan, then you implement your plan, and then you evaluate. So if you follow those 5 steps, you're well on your way to providing good nursing care. Nursing remains a deeply human profession. The compassion, empathy, and expertise cannot be replaced by technology. Instead, technology complements and augments skills, allowing nurses to focus on what matters most, providing compassionate and patient-centered care. Nurses continue to use their intuition and empathy to connect with patients on a deeper level. They provide not only physical care, but emotional support, making a difference in the lives they serve. And I'm going to end on that note. Thank you. So does anyone have anything, like as I was talking, did anything come to your mind about how things had been done, or what memories you have, or?
Well, I've only been here 5 years, and you said 125 beds. So what, besides med-surg and ICU, and we had mother-baby, what were some of the other units that were here?
We had a cancer care unit, a specific cancer care. We had labor and delivery. We had a nursing home. That was not included in the 125 beds, but there was a nursing home here at the time.
Was that in this existing?
No, it was not in this existing building.
Oh, okay.
That part is gone. I do remember when I was working in critical care, if we had a slow Sunday, the nurse supervisor would come down and say, "Judy, get over to the west end," they called it, and get the sisters ready for Mass. So we'd go over there and help them get dressed and make sure the sisters got to Mass. Trying to think what other departments there were.
Wasn't there a mental health unit?
There was a mental health unit, yes, there was a mental health. 2 East was mental health, big mental health unit.
So you mentioned ICU, education, occupational health. What other areas did you work in, and which was your favorite?
Dialysis was the other area I worked in. ICU, CCU, my first 7 years were my favorite.
Where was the dialysis?
Dialysis started out on the 3rd floor in a 4-bed room, and then it moved over to Reed Avenue when we had a Reed Avenue. It was the old Memorial Hospital building, and I think home health care was there, and there was some physical therapy there, and dialysis was on the 2nd floor. And then eventually, I think they decided that's a difficult department to make profitable, and I think that's why they discontinued the dialysis. Great.
Can you say something about how the public perception of nursing has changed over the years?
That's a good question. I hope that patients still trust the nurse. I would think that that's something that has persisted because of that sort of intimate connection you have with them at the bedside, that you really need to be able to trust that person. Maybe that is a good question. I'm not coming up with anything. Roxanne, can you think of, as a non-nurse?
I really think that nurses are still highly respected, and I really don't know if there's been a lot of change in that area.
I think that's why what I think too. I can't think of what the difference would be. My hope is that that is still, and I don't know why it wouldn't be that way.
I know when I do my leader rounding, everybody, all the patients are just, so grateful for the wonderful nurses that they have. So they speak very highly of that compassion and that empathy
Yeah.
that they have.
Yeah, and it's that personal connection that you don't really get from, you get it, but not as, you don't have as much time that you spend with them.
I think what I've seen, I think back to when I was a kid, if I went to the clinic to see the doctor, the nurse would maybe come in and take blood pressure and temperature, but then the rest of the time was spent with the doctor. Going into like the walk-in clinic these days, I mostly see a nurse, and the doctor maybe comes in for a minute and leaves.
Uh-huh.
I think
That's a good observation, and I think that's true. Also, the nurse has a greater role,
greater role and needs to have a lot more knowledge,
more knowledge. Yeah.
almost to the level of a doctor than when I was a kid.
Mm-hmm. Agreed.
I think another change in the last 50 years is we really have medical providers that are physician's assistants and nurse practitioners.
Right.
Years and years ago, it was the doctor and the nurse, and there weren't any middle ground there.
Right.
So, because many times if you go to a walk-in clinic, you're not even seeing the doctor, you're seeing the nurse practitioner or physician's assistant.
Right.
Yeah.
So Judy, yesterday Dr. Berlinden was here and he talked about how the changing role from primary care to hospice. How did you experience that transition of working more with the hospice rather than the primary care providers coming in for their patients? Do you remember that being
I personally didn't experience it because I wasn't working on the floor at the time. But if I was, I think I would have loved having a hospitalist available to me, because otherwise you had to track the primary care down to get an order change. And they were in their clinic, and time-wise it wasn't ideal. Hospitalist, I think, has more, is educated to the role in the hospital better than the primary care. So I think it would have been a nice change for the nurses to have somebody available to them. And plus they get to know them really well. Otherwise you had like 15 different doctors coming in. They know the drill. How things work around here. I mean, that's an advantage.
I've been a nurse for 35 years, and I think the two things that you hit on is we did everything with pencil and paper. Orders were all handwritten by the physician. You had to make sure that you could read their handwriting because it wasn't always easy. You got very familiar with every doctor's
True.
unique handwriting. And then those orders would be manually written out on either cards or on paper and pencil, and that's really how we
Right.
order tests, lab draws, all that kind of thing.
Sure. And when you think about it, all that transcribing from one to another only opens yourself up to mistakes, right?
And I remember also working in the hospital, smoking was still allowed. So nurses and doctors would be smoking at the front desks and in the break rooms. Do you remember that?
I don't, but you're
Oh,
right, because
it
I
was-
remember when
Yes.
when we had the smoking ban. So
Mhm.
and that was a big deal.
Yes, and patients could smoke in their rooms too.
really?
Sure.
Oh my gosh. Isn't that a little-
Yeah.
Back in the
Yes,
dark
yes.
ages. Oh.
I just remember my car mechanic working on my gas line saying, I wish I could have a cigarette right now.
All right, well, thank you very much. I enjoyed kind of this trip down memory lane. There's a lot more when I think about how nursing has changed, but it gets kind of deep when you think about the education and the philosophy of nursing and all of those kinds of things. So I purposely kept it a little more superficial and relatable, hopefully.
Thank you so much, Judy, and thank you for all your years of service.
Thank you.